Welcome everyone to another installment of exercise programming for special populations. It's Mr. G here, and we're going to be talking about cardiovascular conditions and disorders today. Hopefully this one might go a little bit faster than some of the others, only because we have really talked about a lot of these before, but towards the end there are some new ones, so that's where I want you to kind of focus more attention. But let's kind of get caught back up to speed on cardiovascular conditions and disorders. CVD, otherwise known as cardiovascular disease, we already know from multiple courses that it is the leading cause of death in the United States. Atherosclerosis, or a development of plaque in the arteries, is the underlying cause of this cardiovascular disease. We also know that most cardiovascular disease is preventable. There are things that we can do in our lives that we can modify to make the incidence of this far less likely. Things like hypertension, your lipid profile, exercise history, smoking, diabetes, and sedentary behavior. These are all problems that are lifestyle choice related. Things that we actually have an ability to impact, to improve, that actually can help to maybe minimize the likelihood of CVD. However, there are some non-modifiable risk factors that include age, sex, and family history. There's not a whole lot you can do there. I don't care what you tell people about your age. I don't care if you have some kind of operation to alter your gender. I don't care whether you know your family or not. Those three factors are what you're born with. They have a big impact on your genes, your genetic makeup, and they are non-modifiable risk factors. They are absolute. First, let's talk hypertension, and we'll stick to what the textbooks are still referring to it as. Those of you that have followed the news know that the classification for it has changed, at least when it comes to this first part here, your systolic blood pressure. 140 or higher is the old number, and that's the number we're going to stick with. And diastolic is going to be 90 or higher. Lower than that, from like 120 to 140 is considered that pre-hypertensive. That's when we're starting to get close to hypertension or high blood pressure. Also between 80 and 90 is considered pre-hypertensive. And then anything below 120 and below 80 are going to be considered normal hypertension, or sorry, normal blood pressure, not normal hypertension. Hypertension is not normal. Normal blood pressure, and that's what we want to strive to maintain. So you can have one or both. You do not need to have both to be diagnosed with hypertension. You only need one, and it's something that should be measured and confirmed on two separate occasions. There might be reasons why someone's blood pressure might be elevated, so you want to make sure that what you're measuring, what you're reading, is actually in fact a case of hypertension and not a case of something someone ate, or maybe they were a bit too active, or maybe they were nervous because of the situation. Things that can lead to hypertension. It might be elevated cardiac output, or the total peripheral resistance, or a combination of the two. Could be from your diet, taking in too much salt, or maybe you're not taking too much salt, but you have a high sensitivity to salt. Could be a result of chronic kidney disease, kidney dysfunction. However, 90 to 95% of cases are essentially unknown causes. They all kind of get lumped together, and that is referred to as primary hypertension, 90 to 95%. So that's the overwhelming majority. People take meds to help regulate this. Diuretics reduce the fluid load. They might take beta blockers, calcium channel blockers, angiotensin II receptor blockers. ACE inhibitors and these can help to reduce blood vessel tone and allow a little bit more blood flow to help decrease some of that pressure. These individuals that are hypertensive might be on multiple medications. Understanding of the side effects and the effects of those on exercise is important. So it's not so much the blood pressure itself, although that is a concern. It's the medications and what they do. For instance, beta blockers, we know that beta blockers decrease heart rate and they kind of hold it down low. So that might affect our ability to use heart rate as a measurement of intensity, especially when it comes to aerobic exercise. Medications that affect blood vessel tone can cause postural hypotension, which means that they're going to be having a lower blood pressure. And clients must be monitored when moving from a lying to a standing position. So if they go from a lying position to a standing position, their blood pressure could drop dramatically, which could be bad as well. So that's something that can be impacted by some of those medications. Now, that's what meds do. We're going to talk about what we can do by giving some exercise to folks who are hypertensive. We know that regular aerobic exercise can actually improve their maximal oxygen intake, VO2 max. It can improve the efficiency of their heart, and actually it can also decrease their systolic and diastolic blood pressure from about 5 on the systolic and 2 to 3 on the diastolic. This is just from adding aerobic exercise. Adding in the proper amounts of resistance training, that can also lead to a decrease in 3 to 4 millimeters of mercury in systolic and diastolic blood pressure. Whenever you see mmHg, that stands for millimeters of mercury, and that is simply the measurement of how we determine someone's blood pressure. So that 120 over 80 is 120 millimeters of mercury over 80 millimeters of mercury. It is a measurement from the metric system. In addition, any resulting weight loss, so if you lose weight, and you should lose weight if you're doing more exercise, that will also have a positive effect on blood pressure. So all of these things can help bring that blood pressure down just by being more active. Like with any exercise, it should be individualized, but about 30 minutes of aerobic exercise should occur every single day. And they're using the Borg scale RPE here, 12 to 13 on the Borg scale, or 40 to 60% of VO2 or heart rate reserve. Again, if they're not using beta blockers or something that's going to impact their medication. Other than that, you're going to have to resort to the RPE scale if we can't use heart rate reserve or VO2 max as a way of measuring. Now, something to keep in mind, and this is an interesting component here, blood pressure is reduced after we exercise. So blood pressure goes down for up to 4 hours. So perhaps rather than doing one continuous bout where we get 30 minutes of aerobic exercise, it might actually be more beneficial to do multiple short bouts throughout the day, because that will keep the blood pressure lower for longer. Right? More small bouts, and then there's a decrease afterwards, because otherwise it might be up to 4 hours after one session. But if you can get up to a few hours after each session, well, then you're looking at a longer, more effective time of reduction in that blood pressure. Resistance training, 2 to 3 days a week, moderate intensity. That's at 8 to 12 reps at 60 to 80% of their 1 rep max, although a lower intensity and higher volume circuit workout may be more appropriate. Again, the reason why we might want to go with a lower intensity is because one of the things people tend to do, especially as those loads get heavier and we start lifting a little bit more, is people will not breathe properly, and they'll perform the Valsalva maneuver, which is something we never want to do with hypertension. That can spike the blood pressure, make it go up a little bit higher. So perhaps higher volume, more of a circuit, kind of get all the blood flowing everywhere, and a lower intensity, because you don't want people holding their breath and blowing out and increasing that blood pressure unnecessarily. If the blood pressure goes up above 220 on the systolic or 105 diastolic, that is a termination criteria to stop exercising immediately. Now let's look at one that you might not be quite as familiar with, but if you listened along to the chapter where we talked about diabetes, it's something that came up, and that's peripheral artery disease. Now, PAD is the narrowing of non-cardiac arteries that results in reduction of blood flow. So this is going to be to areas of the body where arteries are going to get impeded closer to your appendages. hallmark of it. So what are some things that make us realize that we have it going on? Well, it's intermittent claudication. And claudication is a fancy word for pain in the legs. So that pain in the legs as a result of exercise is something that happens because there's not enough blood flow getting there, because those peripheral arteries are going to be narrowed and closed off and blood can't get there. That's going to cause the pain that's going on in those parts of the body. How do we relieve it? Well, we rest it up. And like CAD, PAD is the result of plaque buildup in the peripheral arteries. So there's actually atherosclerosis in the peripheral arteries, and therefore there are many of the same risk factors involved with developing this, same as CAD. Lots of meds, blood thinners, antiplatelet, vasoactive agents for vasodilation to open up those blood vessels. Statins can help to reduce cholesterol, medication for hypertension. These are all things that are going to go along with someone having PAD. Other disease states like hypertension, diabetes, and dyslipidemia. I'm going to kind of highlight diabetes here because that's one where we typically see people develop PAD. These are also likely to be present, so you're going to want to make sure that you also are watching not only for any medications that are specific to PAD, but also medications that might be specific to diabetes or any of those other morbidities that are there that are comorbid with this condition. Most medications have little or no effect on exercise unless we use beta blockers or other medications that do have that effect on heart rate, so that's good news. Actually, believe it or not, some vasoactive agents that create that vasodilation, open up the blood vessels, that might actually increase exercise capacity. So it's like they're getting a little boost, and you can use that to your advantage potentially. So what does exercise do for us? Effects of exercise. What does it do? Well, that pain in the legs will often determine what we can do, how hard we can go. It will prevent exercise at anything more than low to moderate levels. So you're going to have to keep things on the very low end of the intensity spectrum. But once they actually are able to get going and do some more of this exercise, it will help with that cardiovascular efficiency, anything from lowering their blood pressure and heart rates at a given workload. And with training, clients will be able to increase the intensity at which claudication appears. So that pain in the legs, that's a result of the fact that they have PAD. Through having a little bit more exercise, working on it, they actually will be able to go a little bit harder over time before that pain actually starts to impact their performance, which also will increase the benefits of exercise because you're getting a little bit higher intensity, you're doing a little bit more work in a shorter period of time. Now, if someone has this, it is really, really important to first perform some exercise testing. You want to identify the intensity where those symptoms appear. So figure out where claudication is going to happen. And this way you know exactly where to stop or where to stay underneath in order to determine what's the most appropriate intensity for them to work at. Establish post-exercise ankle blood pressure. That's not something that we practice all that often. But being able to monitor that is going to be helpful for folks with peripheral arterial disease. Gather exercise prescription baseline data, which really is essentially the whole purpose of doing any initial testing. And then identify the presence of any cardiovascular disease if it's not yet determined. More than likely, most of this will happen at the doctor's office, but if they've got pain in the legs, or something to that effect, and they have other conditions, that might be a reason to send them back to their doctor because they might not be aware that they have this, and you want to make sure you have as much information as possible if people are presenting with these signs and symptoms. So don't take signs and symptoms lightly. Just because they don't have something written down on their sheet doesn't mean they don't need to continuously go and get themselves checked out by the doctor, because that's going to help you and help them so that you can program more effectively and more safely. For this disease, walking is hugely recommended. One of the reasons, again, we're looking at lower part of the body not receiving as much blood. So walking is recommended because there's more use of the gastroc muscle. You're getting the gastrocs involved there compared with other exercise modes. So getting that muscle active and moving and facilitating blood flow there is going to be beneficial for folks with PAD. 40 to 60% of their heart rate reserve, or a claudication pain level of 3 out of 4. That's going to be the threshold at which we might want to operate. If they experience claudication, if they have that pain in the legs, they should rest until the pain subsides. And the goal is to work up to the point where they can get through 30 minutes of continuous, sustained exercise without having to rest. Again, that pain, that claudication is going to govern how much, how often you're going to be able to do this. And you want to be able to work your way up. And with time and with patience and with proper programming and proper progressions, this can be done. Guidelines for resistance training are going to be similar to something we'll talk about right towards the end of this particular chapter, which is MI, otherwise known as myocardial infarction or heart attack. Let's talk angina now, another fancy word for chest pain. That's typically what it's called, but it's pain that's not just the chest necessarily. It's the chest primarily, but it's also the surrounding areas. We're talking chest, neck, jaw, arm, and back. And this occurs as a result of ischemia, or reduced blood flow in the heart tissue. And so all that surrounding area might actually be in pain as a result of the reduced blood flow in the heart. Now, the reason this might happen, it's usually because there are narrowed coronary arteries from atherosclerotic plaques. So a little atherosclerosis, the plaques building up and blocking off those coronary arteries, and they can be brought on by physical exertion, which is what we're all about, stress, or any vasospasms that go on too. But exertion is where we'll kind of focus our efforts because that's something that we have the most impact on. Level of exertion at which angina occurs is predictable and reproducible. Now, that doesn't mean we want to go in and necessarily play with it and test it out, but if we have an idea what that looks like, especially from a doctor, and they've cleared them for exercise, or they've cleared us and given us some idea as to how to test, or they've done the test themselves and given us the result, we as exercise professionals can actually determine a suitable symptom-free exercise intensity, because we know once they figure out at what level that this chest pain occurs, we know exactly where it is, and we know how to stay beneath it so that we can give them an exercise program that's not going to cause them any undue harm associated with this angina. They'll take some meds for this, just like with most of the diseases and disorders we're talking about. Things like nitrates, which are a vasodilator, calcium channel blockers, beta blockers. These all have the effect of reducing myocardial oxygen demand, so how much oxygen the heart needs, and potentially increase the functional capacity of these folks, right? Healthier heart, healthier body. Now, the vasoactive drugs, however, might cause dizziness or syncope. Again, lots of technical terminology here. That's why it's important you know them, but I've given some of the more plain English definitions. Dizziness and syncope, otherwise known as unconsciousness, of someone passing out or fainting after the dizziness, especially with changes in posture. So going from a low position to a high position, standing up, that's something that could be a problem. You want to make sure that you take specific precautions to prevent falls if that's the case. So some effects of exercise. When you have angina, if you get regular exercise, it will result in better efficiency of the heart, more tolerance of higher workloads, more higher VO2 max, lower body weight. And the primary goal of exercise programming for someone with angina is to increase the amount of work that can be performed before that ischemic threshold is reached. And that ischemic threshold is essentially the point at which the pain happens. So you want it to get gradually higher and higher. You want them to be able to work out more vigorously without feeling any more pain. And that's going to take a nice, slow, steady progression. That's the primary goal here for folks with angina. Now, with this, if somebody has chest pain, that's one of the things we learned about back in the courses that we take early on in the program, and that early on in the associates program. And I'm talking about health appraisal and all the assessments that we do. We find out if somebody has chest pain or they report chest pain, stop the presses, stop the clock, send them to their doctor, let them find out more. Once they've received that medical clearance and they have gone through some graded exercise tests, which are not what we do, this is going to happen inside a clinic, inside a doctor's office, then they can come to us and we can work with them, use modalities that take them through rhythmic, large muscle group activities like walking, jogging, or cycling. From 4 to 7 days a week, 20 to 60 minutes of intermittent or continuous exercise. Again, remember, it does not all have to be at one time. It's advantageous if it can be, but it doesn't have to be. So if we need to start small and start with little shorter bouts of exercise, that's fine. Just add more of them throughout the day so you can get up to that recommendation of 20 to 60 minutes per day, 4 to 7 days per week. And that threshold for angina, that should be given to you too from a doctor. Where it happens, at what heart rate? Well, now we know, operate no more than 10 to 15 beats per minute below that threshold. That's how we know what our cutoff is and how hard we should make someone work. That's why heart rate monitors and having that kind of technology and those tools at your disposal are going to be important. Resistance training, 2 to 3 times a week, 40 to 60% 1 rep max. Again, intensity determined by those angina symptoms if the onset occurs at less than 40% of 1 RM. So that 40 to 60 is a good number, but if their angina is exacerbated or it is triggered by a load that is going to be less than 40%, you're just going to need to operate underneath the point at which that happens. Okay, so let those symptoms dictate the intensity at which you're going to have somebody working at. For these folks, take your time with the warm-up and the cool-down. They are strongly recommended. And if symptoms appear, so if you do see some symptoms of angina, intensity needs to be lowered. If they have nitrates as their medication, they might need to take those. And if those symptoms persist, if they just don't go down, especially once the exercise has ceased, they need to immediately go to the emergency room. There's a potential that this could be more serious. Next, let's talk chronic heart failure. Chronic or congestive heart failure is the inability of the heart to circulate enough blood to meet our metabolic demands. It can differ in its origin. It can be a systolic or a diastolic origin, which is lower than normal contractility of the heart or failure of the left ventricle to properly contract or properly relax, respectively. So a few different things can be the reason why someone has congestive heart failure. Individuals with systolic congestive heart failure, they have a reduced ejection fraction. We're not going to get into all this, but those with a diastolic failure have a normal ejection fraction but a lower stroke volume. So there's differences in how it is obtained, differences in how they classify. But let's talk more about what causes it in general. Congestive heart failure might be the result of ischemic, again, lack of blood flow and oxygen to the heart, or non-ischemic etiology. So it could have to do with that blood flow, or it might have nothing to do with it. It might be a result of chronic hypertension. Now, because there's less volume, less stroke volume, all that, sympathetic system is overactivated to maintain blood pressure. So the body's all out of whack. The heart is doing more than it needs to. Over time, that's going to cause the muscles of the heart to hypertrophy, to get thicker and stronger, and continued stimulation of that sympathetic response. And it's not strengthening, getting bigger in a good way. Individuals with CHF experience severe reduced exercise intolerance due to the fact that there's a lactate accumulation at lower exercise levels. So now that lactic acid is going to build up, and it's going to cause someone to go into fatigue sooner as a result of having this chronic heart failure. Lots of meds here, things that they can take. Make sure you know what they are so that they can be worked with. I don't need to read them all to you. I've read enough diseases and medications to you at this point. Nothing here that really necessarily is going to be different than what we've said so far. So I'll leave you to this. But if they give you a list of medications, obviously you want to know what they do because that's going to impact your choices of exercise, intensity, etc. If at the bottom here, cardiac resynchronization therapy is used to synchronize the contractions of the ventricles, that might be where they put in a pacemaker, and pacemakers are one of the last things that we get to talk about here in this particular chapter. So let's move on because we will get back to that in a little more detail later. Again, folks who have this, lot lower exercise capacity, more shortness of breath, they're more tired, they're more likely to fatigue sooner, especially at lower workloads. Medications can improve these issues, but they can also have effects on heart rate and blood pressure that can impair the body's response to exercise. So we need to be mindful of those medications as well as the condition itself. Intense exercise, if it is managed, if it's something that they can do, that has been shown, has shown some promise and may actually be safe for some individuals, but let the doctor's note and the clearance dictate what you are actually looking to do in reference to more intense exercise. Some exercise testing should be done to figure out what the lactate threshold is. At what point do they become too fatigued where their muscles and their body starts to kind of shut down? That's going to give us an idea as to what intensities to stay below, what our maximum is, and make sure that we're able to give better, accurate exercise prescriptions. Now, when it comes to aerobic exercise, similar to what we've seen a lot of, the ranges alter a little bit, but 40 to 70% of that heart rate reserve, 4 to 7 days a week, 20 to 60 minutes per session. You notice most of these numbers, when you add them up and you do the math the way they kind of point at it, it still all goes back to that 150 minutes a week of moderate intensity, because that's what this is. 40 to 70% is definitely in the light to moderate range. If you can't use heart rate, again, if they use something like beta blockers, then maybe looking at the RPE scale, a 12 to 14, or maybe a 4 to 5, 5 to 6 on the modified scale could be used. HIIT training, again, for those who are cleared to participate, we already said that might have benefits. So if that's something they are cleared to do and they can do so safely, throw it in there. Resistance, same as usual. Regular activity of any type and avoidance of long periods of inactivity should be encouraged. These are things that are going to help benefit folks with congestive failure. Sorry, I know that got cut off. Congestive heart failure. It'll benefit them. Let's talk heart attacks now. MI, myocardial infarction. That is a reduction or a cessation of blood flow. So either it's less or there's none of it to heart tissue that's caused by a clot or a blockage of some kind of a coronary blood vessel. Now, the severity of a heart attack will depend on the amount of tissue that's damaged and the extent of the reduction in blood flow. Clots, blood clots, plaque and blood are most commonly the result of a rupture of an atherosclerotic lesion. So again, that plaque buildup in the arteries, that getting dislodged and moving up and hitting the and coming up and hitting the heart, blocking it off there, blood clot. That's where we're going to see heart attacks occur. They're related to risk factors that include high blood pressure, hyperlipidemia, diabetes, and family history. All of those we know are also highly related to obesity. So making sure we already manage these other diseases from a prevention standpoint is crucial. But this is also just kind of giving you an idea as to the etiology, how they occur in the first place. Oh, we missed that. That's okay. We've talked about this before. Medications are there. Reduce the work of the heart, maximize blood flow because we want to minimize the amount of tissue damage that's caused by a myocardial infarction. Same kinds of meds we've been seeing for other diseases here of the heart, beta blockers, vasodilators, ACE inhibitors, Plavix, which helps to thin the blood, and reduces, therefore, the chance of blood clot formation, so they don't get to form any of those clots. Statins, those reduce blood cholesterol. Calcium channel blockers, which will help to reduce blood pressure by relaxing and widening blood vessels. Now, one of the things about medications, they can improve that exercise capacity, but just like we've seen with some of these other disorders here in our cardiovascular conditions chapter, it will also have an effect on heart rate and blood pressure. So that impacts the kinds of exercise that we, or at least the way in which we will prescribe exercise. Now, folks who've had a heart attack and they're cleared and they're good to go, believe it or not, the recommendations are generally the same as healthy individuals. Increased VO2 max, increased cardiac efficiency, and weight loss are going to be what we're going to be focusing on the most. Now, the response will be reduced. It will not be quite as pronounced in the general as it is in general population because the heart has been damaged. There has been some cardiac tissue damage. No exercise program should begin for anyone who has had a heart attack without a medically supervised exercise test and a period of supervised training. And I don't mean necessarily supervised by you. This is stuff that might need to happen under the care of a doctor, in a clinic, in a rehab clinic, cardiac rehab center. That's where this is going to happen first before they begin a regular routine exercise program. Just like we saw for the last one, extended warm-up, extended cool-down. We don't want any irregular heart rates, any arrhythmias, because they are more prevalent during, before, and after exercises. So having a little bit more time for the body to generally, to slowly kind of move from rest into the workout stage, and then from that workout stage back down into a resting state. You want some gradual flow between those. So extended warm-up, extended cool-down. Large muscle group aerobic activities, 3 or more days a week, RP of 12 to 16, or you see here they've got 40 to 80% heart rate reserve for 20 to 60 minutes. And again, that can be either accumulated or continuous. So if they can go for the whole round, that's fine. If they cannot, intermittent bouts, so short, 5 minutes here, 10 minutes there. However much you need to do to add up to get the proper amount here. Resistance training, 40 to 80% 1 rep max using 8 to 10 circuit training stations. So we're kind of training the whole body, a little bit more specific in what they're telling you to do here. You can obviously choose the exercises, but we're starting to kind of see a little bit more specificity in terms of how you should train someone following some of these issues or diseases, conditions. Atrial fibrillation is one of the most common arrhythmias that is increasing in prevalence. It is an electrical malfunction where the atria depolarizes very rapidly, up to 300 times a minute, and that's going to result in uncoordinated ventricular contraction. So the heart is just kind of pulsating and not doing what it's supposed to. It's not beating the way that it's supposed to. AF, as it's called, present in a number of conditions, including hypertension, CHF, coronary heart disease, and valvular heart disease, which we have not gotten to yet. But atrial fibrillation seems to happen along with these other conditions that are cardiovascular in nature. Take some meds. The goal here is to prevent clot formation. Beta blockers control the ventricular response. This might also help to improve exercise capacity. AF reduces stroke volume and cardiac output by about 20%, which results in someone fatiguing earlier when it comes to exercise. So keep that in mind working with someone who has this. And the exercise professional should be aware of the effects of exercise on the underlying conditions as well. So you're not necessarily programming just to atrial fibrillation. You're going to be programming to atrial fibrillation along with whatever other conditions or disorders they might have that actually cause it in the first place, whether that be coronary heart disease, heart failure, or congestive heart failure, hypertension, you name it, whatever was just on the previous slide. Everybody's different and how much they can tolerate. That will also depend on how many comorbidities, how many other issues they have along with this. Medically supervised graded exercise tests should be performed in order to determine that intensity. When they come back to you and the doctor signed off and has given that to you, then you can start to come up with the right intensities and the amount of work that someone needs to do aerobically. Large muscle group aerobic activities, 4 to 7 days a week, RPE of 13 to 16. You see it's a little higher here than in some of the other ones, so there's a little bit more intensity you can go with. And again, use RPEs because exercise heart rate, because remember, this is an arrhythmia, an irregular heart rate. That might not be the most efficient way of measuring intensity. So rather than going at heart rate reserve, maybe using the RPE scale is a little bit more reliable to kind of give you an idea as to how hard somebody's going. Moderate intensity resistance training, 2 to 3 days a week. Again, more circuit training format here, 8 to 10 exercises. You want to hit all parts of the body. Active lifestyle throughout the day should be encouraged. No sitting around and being sedentary. HIIT training can be appropriate, but look for that doctor's clearance before you go ahead and get crazy. Now, I mentioned that we would talk about this later, and here it is. Pacemakers and defibrillators. And I'm not talking about like an AED that's in the class, although the function is the same. But there are certain conditions that may create a need for someone to have a pacemaker or an ICD, which stands for an implantable cardioverter defibrillator, put into their bodies. These are used because of electrical disturbances in the body that result in either a high, low, or disorganized heart rate. And this can cause a number of issues, including lightheadedness or possible fainting, going unconscious. We don't want that. And what these devices do is they help to regulate the electricity in our body. They help to minimize those disturbances, and they will then restore or optimize the heart rhythm. Underlying causes for the need for these range from a number of the diseases that we talked about, including one that we didn't mention, which is sick sinus syndrome, which is dysfunction of the SA node. Abnormal heart rhythms, they have to be corrected. If someone has one and it's no good and doctors have figured it out, it needs to be corrected. Otherwise, that heart rate and the blood flow is not going to be what it needs to be. And the blood isn't going to go to areas, and there might be more tissue death and insufficient blood flow to other parts of the body. No good. That's going to impact general functioning, and also it'll impact the ability to essentially survive. So we want to have this put in if we find out that there is an abnormal heart rhythm. Most cases, this is the treatment, but sometimes other medications might be there because of maybe the issues that cause the need for it in the first place, those comorbidities. Exercise capacity can be improved with the use of the device because the device regulates the heart rate better, but it will be affected by the presence of those other comorbidities that will be around as well. So you want to watch out for those. If that pacemaker is effective, which hopefully it should be for having something put into your body like that, the response to exercise training will be consistent with the expectations associated with the comorbidities instead. So you don't even have to worry about it if it's functioning properly. You just have to worry about the comorbidities. You still want to know it's there, however. Medical clearance is crucial. Should be obtained and then exercise prescribed in light of these other conditions. First few weeks of exercise, especially after having that put in, should be at an intensity that is not likely to mess with or alter the integrity of that recently implanted device. After that, after it's had a time to adjust, exercise prescription will vary according to the existence of those comorbidities. The only thing that you should know is that the heart rate should remain 10 to 15% below the rate that would trigger the device to fire. So that's all information that should be included with the doctor's clearance and the instructions for exercise. Now, if you're working with somebody that has one of these, you want to know some symptoms that will tell you if something is wrong, especially if it's something wrong with the device. It might be undue fatigue, syncope, so passing out, dyspnea, that's shortness of breath, dizziness, Heart palpitations, tachycardia, bradycardia. Again, these are all irregular heart rhythms. That's a huge sign that something is wrong, and it might be something wrong with the actual device itself. Finally here, we get to valvular disorders or valvular heart disease, VHD. That is incompetence of one or more heart valves. Results in reduced or inadequate blood flow and an increase in the pressure in the chambers and the size of the chambers. So that can lead to myocardial hypertrophy. So the heart actually gets enlarged. The valves can actually go through stenosis or stenose, which is a narrowing or hardening of the valves, or they can fail to close completely, which results in retrograde blood flow. If you know anything about the heart and the path in which the oxygenated and deoxygenated blood flows and how it moves from chamber to chamber, you know how important the integrity of that system is. And so if something causes those valves to close off or fail to close off completely, that's going to cause issues that are going to have major ramifications. Some things that can happen here to cause it, it might be a result of aging, and the other stuff are things that we really don't have a lot to do with. Rheumatic fever, which is an inflammatory disease of the heart, joint, skin, etc. Any kind of birth defects, an infection, issues that really are not lifestyle related, other than aging, and even that's not lifestyle related, that's just living. Symptoms of it: dyspnea, fatigue, being tired, some pain, general pain, and heart palpitations. Lots of different medications here. You might see atrial fibrillation, CAD. These are common comorbidities, and the medications that you take might reflect some of the issues that you need to be concerned with. A lot of the medications listed here are the same as what we've mentioned earlier. Again, these can affect your exercise capacity and your heart rate, so that's going to impact how we choose to prescribe intensity. There might be possible side effects, of course, with any type of medication that someone takes, but these medications do generally improve the exercise capacity of someone with a valvular disorder. If this is bad enough, they might actually have to have the entire valve replaced entirely. Again, that's all dependent on the severity of their symptoms. When it comes to the effects, well, it really depends on how many comorbidities, how severe those are, and how severe the valvular disorder is. Minimal symptoms, if they've got minimal symptoms, normal exercise is what we can give them, and they will have a normal training response, so that's good. If it's more moderate, the exercise response is going to be dependent on their worst comorbidity. So looking at the other conditions, especially the ones we mentioned earlier, that's going to dictate exactly what kinds of benefits they'll derive. And then if they actually have very severe symptoms, and it's severe even at a resting state, you might not even be able to exercise at all. So we have to step out entirely. It all depends on the severity here. Finally, medically supervised testing is recommended. When it comes to aerobic exercise, again, depending on what they can do, 40 to 80%. So nice big range there, getting a little bit higher on the end of moderate, a little bit closer to vigorous. 12 to 16 on the RPE scale. Whether it's continuous or accumulated, you want to get that 20 to 60 minutes in, and 4 or more days a week. Resistance training, 30 to 50% 1 rep max, 1 or 2 days a week. So notice that that one's a little bit less than usual. And comorbidities might impede all resistance training in individuals with symptomatic aortic or pulmonary stenosis. So if they've got anything there, they might not be able to do any kind of strength training at all. If you can work out with these folks, however, longer warm-up, longer cool-down, again, a gradual change in activity level. That's all we got for you here, ladies and gentlemen. Expect to have a little quiz to go along with this. That'll be available on Blackboard sometime soon, so stay tuned. Coming at you. Thanks for listening. We'll see you next time.